Hello, my name is Dr. David Theodoro. I'm a heart surgeon and am privileged to lead the heart surgery program at St. Dominic's Hospital here in Jackson, Mississippi. What I was hoping to do during our time together is to explain and simplify what can be some relatively confusing issues about your heart. As we move through our time together, I would like you to keep one major theme in mind, that the heart, while a very sophisticated muscle, has one primary or one sole purpose, and that is to move blood forward in efficient and effective as fashion as possible. So when we talk about different components of the heart and we talk about different problems that can arise within the heart, please keep in mind that the heart's sole or primary purpose is to move or pump blood forward effectively and efficiently. I've referred to the heart as a muscle. So when you think of a muscle, you can think of your bicep muscle, you can think of your leg muscle, and the heart is a muscle just like that, only much, much more sophisticated. We can actually also think of the heart as somewhat of a hollow muscle, in that on the inside of the heart there are 4 compartments or chambers. And each one of these chambers has its own particular function. The heart also has its own dedicated personal blood supply, if you will. I'll refer several times during my remarks to the heart and its analogy to that of an engine, so to speak. So if the coronary arteries are the heart's personal blood supply, it can also be, or they can be considered the fuel line of the heart. And so just like a car engine has inside compartments, so does the heart. Just like a car engine has valves, so does the heart, and we'll explain that. And just like a car has an electrical system, usually that of the battery in the car, so does the heart. And we'll make comparisons and analogies between the heart and a car engine, so to speak. So let me start with the coronary arteries that I've indicated would be the heart's own personal and dedicated blood supply or fuel line. Typically, when we think of coronary arteries and what can go wrong, we think of the coronary arteries being a place where blockage can occur. That blockage can happen with cholesterol buildup, fatty buildup, calcium buildup, anything that causes the blood flow to be interrupted is bad, and we would refer to that, and what you hear on television is coronary artery disease. And it's coronary artery disease, in other words, the fuel line of the heart's personal blood supply or fuel lines are clogged. And if they get clogged bad enough, such that blood is completely shut off to the underlying heart muscle, well, then a heart attack can occur. And so we hear about heart attacks, and we hear that there are likely some 1 million heart attacks in this country every single year, and that problem arises from the blocked coronary arteries. And lots and lots of different ways that we can look for this particular problem. Typically, patients will come to their doctor indicating that they're short of breath, that they are easily tired during exercise. It wouldn't ordinarily tire them, and oftentimes they have associated with shortness of breath and fatigue chest pain. Chest pain can be anywhere from classic and in the center of the chest to pain that is from the heart but doesn't necessarily have to be right in the center of the chest. We hear of shoulder pain, of neck pain, of pain that starts in the shoulder of either the left or the right arm and then travels down the left arm in particular, sometimes the right, but most commonly the left. These are all potential signs and symptoms of blocked coronary arteries. And again, that's very, very important, because those symptoms could be the precursor or the warning signs of an impending heart attack. And we also know that there can be differences in these symptoms and pain patterns between men and women. Oftentimes, women will not present even though they have very badly blocked coronary arteries, with classic chest pain that occurs in the middle of the chest. Many, many times I hear our women patients complain of tiredness, fatigue, shortness of breath, and even indigestion. I would say indigestion is the most common sign or symptom that typically gets passed off as something other than coronary artery blockage. But I think that we've got to be very, very aware that this problem can present itself in many, many, many different ways. If we continue on with coronary arteries before we move on to the next component that's very important to understand about the heart, there are many ways that we diagnose this problem when a patient presents with the signs and symptoms that we've talked about. First is a good physical examination from either your primary care physician or most commonly a cardiology doctor. They will listen to your heart. They will usually take a so-called EKG, which is an electrical pattern that the heart generates, and oftentimes this electrical pattern is altered when the coronary arteries are blocked. If there's worry about coronary artery blockage after these two sort of simple means of diagnosis, then oftentimes the cardiology doctor will offer the patient a so-called stress test. That can be a test whereby you're hooked up to an EKG machine and either walking on a treadmill to increase your heart workload and heart rate to see if there's any evidence of blocked coronary arteries. And if one can't walk on a treadmill, then we can give special medications to increase the heart rate and the workload, so to speak, of the heart to see if we can't unmask any clogged fuel lines or blocked coronary arteries. And then the gold standard is a coronary angiogram, which is really nothing more than a procedure whereby the cardiologist introduces contrast material or dye into the coronary arteries in a very sophisticated way, and then a movie is taken. We call it an angiogram, and that movie follows the contrast material or the dye through the coronary artery anatomy, through the tree, through the fuel line, so to speak, and tries to see and detect any blockage, any narrowed areas in the coronary arteries. And if that's the case, well, then we have a diagnosis. Let me go back one step. We've talked about the EKG, we've talked about a good physical examination and even a stress test, be that a treadmill or a nuclear stress test. Let me talk about something else that I see very common here at St. Dominic's, and that is patients that have undergone the so-called healthy heart scan, which is really just a CT scan of the chest with the sole purpose of picking up calcium deposits. We talked about calcium deposits and cholesterol and fatty deposits in the coronary arteries as a means of blocking the coronary arteries. Well, this healthy heart scan is excellent at picking up calcium in the coronary arteries, and that oftentimes, quite frankly, is the very first test that suggests that something is wrong, and it's that test, when determined to be abnormal, will trigger the progression through the other tests. Again, nuclear stress test, treadmill stress test, and then ultimately an angiogram. So that's sort of the way that I typically characterize and categorize the coronary arteries and what can go wrong with them. If we're going to finish our discussion relative to coronary arteries, and let's now pretend, for the sake of this conversation, that there are blockages and that there are blockages that are interfering with the efficient flow of blood through the fuel line of the heart, the coronary arteries. And let's also assume that medical management, that is taking a pill or a series of pills, is not going to be enough to improve blood flow. So now the two major treatment options that every patient has when they have coronary blockage that needs to be treated is something that we refer to as angioplasty, usually angioplasty with stenting, and bypass surgery. Let me explain both of those briefly and in as simple a fashion as I can. If a patient has a blockage in a coronary artery that is really a relatively small vessel, it's about half the size of a typical straw that you would use to drink your soda from the fast food place that you shouldn't be at, by the way. But nonetheless, the coronary arteries are small, and the cardiologists are experts at positioning a small, deflated balloon right in the area of the blockage, and then the balloon under visualization with some fancy tools in the so-called cardiac catheterization lab. The balloon is expanded right at the area of the blockage. And when I say blockage, think of the narrow part of an hourglass. So the sand is up in the top of the hourglass, then there's the narrowing, and then the sand drops through that narrowing into the bottom part of an hourglass. That's exactly what coronary artery blockage looks like. And so the cardiologist, to use that analogy, positions his balloon right at the area of the narrowing of the coronary arteries, or in the hourglass, for instance, and then expands that balloon and pushes the blockage out of the way, out to the side wall of the straw of the hourglass or of the coronary artery. And then in order to keep that vessel from springing back into a blocked area, the cardiologist positions a little wire cage that we call a stent, and the stent props that vessel open. That's actually now the most common way that people have coronary artery blockage treated mechanically, so to speak. When I say mechanically, it means that the coronary artery blockage is beyond medical management. So the most common is angioplasty, which is the balloon, and propping that area open with a stent. So we talk about angioplasty and stenting. If that's not able to be done, and treatment is required, well, then we need to move to what I and my colleagues do most commonly, and that is something called bypass surgery. When I explain bypass surgery, I explain it as fancy plumbing, basically. We use typically a vein from a patient's leg and an artery from up underneath the breastbone. Everybody's got these vessels, and they can be repurposed, if you will. The veins taken out of the legs and the artery disconnected from its natural position under the breastbone, and as I mentioned, repurposed for brand new coronary arteries. And that's really all bypass surgery is, fancy plumbing, whereby we build brand new coronary arteries and leave the old blocked ones alone. We just simply go downstream from where the blockage is and tie in down below and up above the blockage, and now the blood has a brand new route to flow through, either through the vein from the leg or the artery from up underneath the sternum or the chest bone. And now blood flows typically through the path of least resistance, and if there's resistance in the blocked artery, then the blood would much rather and more effectively flow through the new bypass graft. So those are the two major ways that we treat coronary artery blockage: angioplasty and stenting, and bypass surgery, fancy plumbing. So now let me move to the inside of the heart, but remind the audience that once again, the heart is a sophisticated muscle, and it has one sole or primary purpose, and that is to effectively move or pump blood through both itself, the heart, and the rest of the body. And one thing that I find interesting and helpful when I explain this to patients, the blood as it moves through the heart is designed to move in a complete one-way direction. So once blood leaves a certain chamber, remember we talked about the heart having 4 different compartments or chambers within itself, 2 on the right and 2 on the left, 2 upper and 2 lower. An upper on the right and an upper on the left, and a lower pumping chamber on the right and a lower pumping chamber on the left. I'm not going to name them beyond that. It just gets too confusing. But if you were to pretend to be on a blood cell riding through the heart, you would start in the right upper chamber and travel through the right lower chamber. Then you would pass through the lungs to pick up oxygen, end up in the left upper chamber, move from there to the left lower chamber and be pumped or moved out of the heart to the rest of the body. And then the ride continues through the body and you end back up in the right upper chamber, and it just continues to cycle in a one-way direction. Well, the way that that happens on the inside of the heart is that the blood moves from one chamber to the next through a so-called one-way check valve. They have fancy names. We may or may not worry about the names, but when I say check valve, think a one-way swinging gate. And every single chamber in the heart, again, of which there are 4, has its own personal one-way check valve or swinging gate that blood has to move through to get to the next chamber. So the valves on the inside of the heart have as their sole purpose the effective and efficient one-way flow of blood. Now they function in service to that purpose by opening freely and closing tightly. So the way these valves were designed, even though each of the 4 valves have a little bit different characteristic that is way beyond what's important to talk about during our time together, the bottom line is all 4 valves need to, when they're normal, open freely and close tightly, such that if you were on that blood cell journey and you passed through one of the swinging gates or one-way check valves, there would be no way for you to go backwards through that valve if the gate or the check valve was working appropriately. So that's normal. Let's talk about abnormal. The way that the valves behave abnormally, and the most common valves to behave abnormally, by the way, are the 2 on the left-hand side of the heart. I actually will mention their names because your doctors will mention their names. One of them is called the mitral valve with an M, M-I-T-R-A-L, and one is called the aortic valve, A-O-R-T-I-C, the aortic valve. And we'll just simply talk about them now as the one-way check valve or the swinging gate. The most common way that the aortic valve malfunctions or misbehaves is becoming stiff and thick and non-pliable, and therefore, while it still may close tightly, it doesn't open effectively anymore. The doctors give that condition a name called aortic stenosis, and all that means is the aortic valve, instead of opening freely, doesn't do that anymore. It closes tightly in many cases, but it doesn't open well. The next most common valve abnormality now goes to the mitral valve, and the way that the mitral valve most commonly malfunctions or misbehaves is not by becoming stiff and not opening well, but closing very poorly, to give a condition called mitral valve leakage, mitral valve regurgitation, or mitral valve insufficiency. Let's leave out the 2 latter names and just call it leakage. So the 2 most common valve problems that patients across the world have would be aortic valve tightening or stenosis and mitral valve leakage or insufficiency. Now, any valve of the 4 can become leaky, and any valve can become tight, but the most common are those that we talked about. And if we remember that the sole purpose of the heart is to move blood, pump blood effectively and efficiently in a one-way direction, now you can see the tie-in to a valve problem. If the valve doesn't open appropriately, it becomes stiff, it becomes calcified, it becomes sort of, if you will, stuck in the almost closed position. Well, now blood can't move effectively and efficiently through the heart in a one-way direction. And similarly, if the mitral valve, while opens beautifully, closes terribly and allows blood to leak backwards, again, now the heart can't fulfill its number 1 purpose of one-way effective and efficient blood flow. So when the valves become bad enough that the heart can't do what it was designed to do, now we have to think about treatment. And the most common treatment for the type of aortic valve problem, that is a tight valve problem, is to simply replace the valve. With new technology, many times that would be something that the heart team can do, and I do stress the heart team, both cardiology doctors and cardiac surgeons and many other important members of the team work together to replace the aortic valve nowadays in a way that doesn't require open heart surgery. It's called the TAVR, or the TAVR procedure, and that'll be a conversation we can have during our next 20 or so minutes together. But that's a way that the aortic valve can be replaced, usually using an artery in the upper part of the leg, kind of like a very sophisticated coronary angiogram or heart catheterization, and we position a brand new valve in the area of the old valve, and we release that valve, so to speak, in two different ways, but again, the details aren't important. And that valve, if you will, springs into action and pushes the old valve out of the way. And that is in fact, perhaps the most common way today that we treat aortic valve tightening. Mitral valve leakage, the other or the second most common valve problem, is typically treated, when it needs to be treated, with a mitral valve repair and in some cases mitral valve replacement, but that's most commonly still going to require open heart surgery, where the heart surgeon and his team use certain well-established maneuvers to actually do nips and tucks and shrinkage procedures, so to speak, on the mitral valve to make it close tighter again and stop the leakage. Again, the aortic valve, while we've talked about it being tight, it can also be leaky, at which point, if the leak is bad enough, then that valve needs to be replaced. And similarly, the mitral valve, while most commonly leaky, can also be too tight, at which point mitral valve replacement, not repair, is necessary. So that's really the highlights of the heart and the inside very sophisticated valve and how they normally function and how they can malfunction or misbehave. So we've talked about the coronary arteries as a major important component of the heart. We've talked about the internal valves of the heart. We're going to once again remember that the heart's sole purpose is to effectively and efficiently move blood forward in a one-way direction. And I'd now like to comment very briefly on the electrical system of the heart. The heart has its own very sophisticated electrical network and an electrical system. I believe probably most in the audience would be familiar with the terminology atrial fibrillation. It's very hard to turn on the television now without hearing an advertisement for medication that is typically used in patients that have this rhythm disturbance called AFib. Let's just, for the sake of this discussion, characterize atrial fibrillation as a very common, very abnormal heart electrical rhythm disturbance. And so, again, the heart has its own personal electrical system that needs to work in a very standard way, where tiny little transmitter pieces of tissue talk to the electrical network and relay signals through another very sophisticated set of electrical tissue that are anatomically positioned in the heart in a really beautiful way. And when anything disturbs that electrical system, well, then things can go a little haywire. And things going haywire in the two upper chambers of the heart. Remember, we talked about the heart has 4 chambers, 2 lower pumping chambers and 2 sort of receiving upper chambers. And atrial fibrillation interferes with the electrical system of the upper chambers, and things do go a bit haywire and are a bit chaotic, if you will. And what that means, if we return to our constant theme of the effective and efficient one-way movement of blood through the heart, when the two upper chambers are behaving out of concert or out of sync, if you will, with the two lower chambers, well, that interferes with the effective and efficient movement of blood, which is the heart's sole and primary purpose. And as a consequence of this sort of chaotic electrical activity in these upper chambers, the blood can become somewhat stagnant, and typically the advertisements on television are talking about medications in the face of atrial fibrillation that help serve to thin the blood. So one of the horrible consequences of atrial fibrillation, and that is a blood clot that moves to the brain from the heart and gives a patient a stroke. And so whenever we think of atrial fibrillation, we can go back to our fundamental home base. The heart needs to effectively and efficiently pump blood in one direction, and with atrial fibrillation, it can't do that anymore. The blood can become stagnant in the upper chambers, especially the left upper chamber, and if it becomes stagnant enough in some little recesses of that upper chamber, clot can form. If that clot were to leave the left upper chamber and travel again to the brain, a stroke can occur. And that can be a devastating consequence of atrial fibrillation. In addition, the chaotic electrical activity of the upper chambers can in some way be transmitted to the lower chambers and cause those chambers to not work as effectively and efficiently, again, interfering with the heart's sole or primary purpose of good blood movement. There can be a host of other electrical abnormalities, and probably the next most common, and right there with atrial fibrillation, is just sort of a short circuit, so to speak, between the two specialized relay areas. One is a sort of a battery area, and one is more of a relay area. And if there is a loss of communication or a slowdown from the impulse area in the upper heart, well, then the heart rate becomes particularly slow, if not completely interrupted, and that would be the reason that patients would need a pacemaker. And so those are the two most common problems with the electrical system. There are some more sophisticated problems that your cardiology doctor, and in particular an electrical expert cardiologist, we call them electrophysiologists, but they're doctors that have gone all through their cardiology training and then dedicated even more training and then generally their career to focusing solely on the electrical part of the heart. And whenever we have patients with atrial fibrillation, and pretty much whenever we have patients that are in need of a pacemaker because of this short circuitry or the interruption in the electrical system, it's the electrophysiology doctors, the electricians of the heart, that are the specialists in the if you will, the domain experts that help us with these problems. So we've covered a lot of ground today. We've once again characterized the heart as a super sophisticated muscle, kind of a hollow muscle with four chambers on the inside, a muscle that has its own special dedicated personal blood supply, the coronary arteries, that if they get blocked can give a heart attack. We treat that with either angioplasty and stenting or bypass surgery when it's needed to be treated. We've talked about valve problems with the valves even being either being too tight and not opening effectively, or too loose and not closing. And your cardiology doctor and or the heart surgery doctor can help guide patients through that journey on diagnosing any of these problems that we've talked about: coronary artery problems, valve problems, or electrical problems, and try to marry that problem with the most effective solution. So I appreciate your time, and I appreciate this opportunity to share some of my thoughts and how I try to categorize what can be and characterize what can be a very daunting and sophisticated group of issues and problems that can affect your heart, and how we try to break them down into a manner, or in a manner such that we can all understand and have a good and patient-centric discussion. Thank you very much.